So thank you. I very much appreciate you having the format in this way. I hope all goes well. Things certainly get harder as time goes on. I think you can all appreciate balance um, between trying to, I'm also, besides the things she's described, a mother of three children, and so traveling becomes harder and harder. I'm finding as time goes on, squeezing that in. So thank you. I'm speaking today, I believe, in my capacity as chair of the Frail Senior Medically Complex Task Group, which I've had the pleasure of being for the last, I guess, 3 years now, as we've worked to implement the Assess Restore framework with the Ministry of Health. So I'm hoping that this is going to work as I scroll through. So what I was asked to do today was to start by providing an introduction to the Rehab Care Alliance, which is the organization within these initiatives are taking place, to look specifically at the Frail Senior Medically Complex Mandate 1, and now we're just towards the end of Mandate 2. Look specifically at what we've learned through our direct access priority process projects. And then, of course, I'm most familiar with the Northeast LHIN, and so lessons learned through the example of some of the projects, and specifically the Northeast LHIN's experience with implementing this process. So our first mandate, the RCA, for those of you who are less familiar, was established in April of 2013 for a 2-year mandate. It was established by the LHIN CEOs, and what the RCA Secretariat created a province-wide collaborative network, which looked to build on the previous work of rehabilitation and complex continuing care expert panel. And they are brought together representation from the LHINs, from the Ministry of Health, health service providers, both from hospital, community sectors, patients, and caregivers, and essentially focusing on improving patient experience and clinical outcomes, and in particular for rehab services across the care continuum. So you can see all of the RCA, they have a website which is equipped with all of the reports that have been created, the full reports as well as the summary reports, and then of course relevant links to the work of their first mandate and second mandate, and focusing specifically on 5 areas of focus. So in the first mandate, there are essentially 5 priority areas that were created. I actually think the first one was definitions and capacity planning. And then the second one was system evaluation. So the definition and capacity planning looked specifically at creating definitions to describe rehabilitative care for various populations. So looking to standardize the definition of rehab care, so clinical components of rehab programs, looking at what those look like, what's the framework for that to create a foundation for capacity planning. System evaluation priority area looks more at developing an evaluation framework to support the evaluation of rehab care services, both provincially, regionally, at the local level as well. Frail Senior Medically Complex will talk more about moving forward. Outpatient and ambulatory, they looked more to develop a minimum data set for ministry-funded outpatient rehab care programs to support data collection, standardized metrics, and then to enable more appropriate evaluation, as there was very little standardization across the province in this area. And then the planning considerations for reclassification. So what are the impact of reclassifying CCC and rehab beds? What are the issues related to reclassification across the province? So those were the first mandate deliverables. There was advisory and task groups developed around each of these areas. And as stated, I am most familiar with the Frail Senior Medically Complex. It was a first mandate, and a report was developed in each of these areas. The second mandate, which started in February of 2015, was essentially to look to further the work of the first mandate in terms of supporting and implementation. So the first mandate was approved, the second mandate was approved in February to go through till March of 2017, and the RCA in the second mandate essentially a coordinating, supporting role of the implementation of all the deliverables that were identified in the first mandate, taking us through to March of 2017. When looking at the second mandate, there were 3 pillars that was asked of the RCA. So to provide ongoing project management and support to the LINs, to help guide the implementation of the processes that were developed in the first mandate. So the tools that were brought forward, the frameworks and the processes to help guide implementation province-wide. To support the LINs and the Ministry of Health with assess restore related initiatives, again looking to facilitating knowledge exchange and implementation of the assess restore guideline, and to support implementation of existing QBPs through identification of standardized rehabilitative care practices across QBP handbooks were not already defined. So the assess restore frail senior medically complex mandate. So this was the group that I worked with, and I'm sure many who are listening today were involved with. And we were tasked in the first mandate to develop a rehabilitative care approach for frail senior medically complex populations to help support the operationalization of the priority elements of the essential elements of assess restore framework. So you may remember that back in December of 2012, Living Longer, Living Well was a seniors strategy was published, co-authored by Dr. Samir Sinha. And in that, he defined essential elements of an assess restore framework. And you can see this was a fairly busy representation, but those of us who work in this area can appreciate that this is how we feel most days, trying to navigate this system. We have focused in our mandate the component of this assess restore guideline that is framed in the red upside down, say, triangle. Oh. Can you ask if people can see your slides? No, that's okay. Sorry, guys. I was just asked to pause for a minute. Are people having trouble seeing my slides? I'm getting feedback that possibly you can't see my slides.
Ottawa sees your slides.
Okay. Okay. All right. I'm going to continue then. So we were asked, we focused on this component when we first started to meet and essentially asked to develop or implement assess restore for frail seniors. As you can imagine, it was a fairly overwhelming ask because assessment, identifying functional decline, restoration can take on many different settings, many different areas, can be because of many different causes, often because of multifactorial causes. This could happen in the home, it could happen in long-term care, it could happen in hospital, and the ways with which you address, identify, and support that is heterogeneous and cross-continuum. So we had about 18 months and thought, where could we make the most difference? Where could we do our work? And at the time, there had been a fair amount of work in senior-friendly hospitals and through the Move On initiative. And so we felt that we would focus on the community dwelling older adult. The population is those who had experienced functional decline, reversible with restorative potential. And those, how could we get them, for those where it's appropriate and needed inpatient rehab, how could we get them to inpatient rehab and avoid essentially presentation to the emergency department or hospitalization in between? How can we facilitate that process in a quick, streamlined way? So through that process, we did work to develop what was since called a provincial priority process to support direct admissions to bedded levels of rehabilitative care from the community as well as from the emergency department. So if those folks were already presenting to the emerge, how can we get them into a rehab bed and avoid hospital and all the things that we know hospital can do to frail older adults. We developed a toolkit to assist those working to do this. The ministry very much wanted us to come up with, as much as possible, tools or standardized processes to do this. We were not successful in identifying, and those of you who work in geriatrics can appreciate that there is no simple tool for functional decline. There is no simple checkbox. There is no simple assessment for restorative potential. Those are things that you can only do through comprehensive geriatric assessment. But we did feel the assessment urgency algorithm provided a sense of risk, and that has been validated in the emergency scenario, and in some cases in community, in terms of identifying risk. So risk being, if nothing is done, this person is at imminent risk of requiring higher level of care, either hospitalization, long-term care admission, or essentially. And so we felt that would help us pick out those folks who had functional decline, who were at high risk, and then that would help us identify them, and then they could be moved into a more comprehensive geriatric assessment. There was, they identified possibly a standard referral form which could be piloted for use to support this process. So once the person was assessed and determined to have restorative potential, they could be referred directly to inpatient rehab. There were some process and outcome evaluation indicators identified. And then we developed, this is not new information, but instead a compendium, so put together a guide for rehabilitative care best practices for the frail older adult. We became very aware that this was in fact a new language, a new way of looking at rehab. So we've taken the model from, what is something very, I would say, very concrete, which is, say, a hip fracture or a stroke, where someone is functioning at a particular level, they have a catastrophic event, and then we move them into rehab to see how we can improve abilities and restore what was lost and optimize function and quality of life, cognition, those sorts of things. But with functional decline in the community, without that sort of acute event, it was much more difficult to discuss that, to have people get their heads around that. And then in particular, we're then putting them into rehab, and there was this concern that we know as geriatricians and those of us who works in geriatrics that the geriatric syndromes are in fact what confer the greatest amount of disability, frailty, incontinence, functional mobility decline, pain, constipation. These are things that impact, that have a greater impact on disability than just about anything. And some studies would suggest more so than stroke, more so than cancer, more so than heart failure, more so than COPD. And so if we were to transition these folks into rehab without developing an approach or arming rehab with what are best practices to assess the geriatric syndromes, that in many cases these rehabilitation areas may not have expertise in geriatrics, and so if we aren't arming them or teaching them how to manage geriatric syndromes, identify geriatric syndromes, and then work to modify them, then we may not in fact be achieving the outcomes that we'd want. So develop that compendium. So these were the areas in the mandate, in the first mandate that we worked on. So specifically highlighting how do you screen for functional decline in the community. Once you've seen functional decline, they're at high risk. How do you move them quickly into assessment to determine what if they do have functional decline, if there is restorative potential, and what's the most appropriate place for them to go, if that's outpatient rehab, if that's comprehensive geriatric services and community supports, or whether it's inpatient rehab. How do we get them placed and navigated to the most appropriate provider quickly without duplication of assessment? We don't want people assessed at the screening, assessed again, and then assessed for placement. That process should be that one process. And then once they're in the intervention, what's the most appropriate place? Is it subacute complex, geriatric rehab, active recuperative intervention? And as many of you know, where rehab is done in many communities is different and heterogeneous across the province. And then how do we transition home with appropriate linkages to primary care and other community supports, i.e. ongoing rehab and restorative care once people are in the community. So this, some of you may be familiar with, this is our placemat essentially slide. So this is the process we developed in the first mandate. Step one was early identification and screening. We identified that could potentially happen in CCAC, at the community support sector, within primary care, or within the emergency department. Screening could happen either through identifying functional decline and then utilizing the assessment urgency algorithm to confirm high risk, but not to replace clinical impression as the gold standard for functional decline and a change in functional status. So in some communities where there may not be a strong primary care, I'm thinking of northern communities, for example. So it might simply be the community support sector or CCAC, part of their 90-day reassessment where they can identify there's been a change in functional status. In primary care during a time of checkup, or perhaps they're presenting because of change in the functional status, and then certainly once people are into the emergency department. So if they do screen as being high risk, referral for urgent comprehensive assessment, and who that should be will again depend on these services. Ideally, the gold standard would be comprehensive geriatric assessment through specialized geriatric services. There are, however, models of care where this type of format, this type of expertise has been developed within primary care. And we will show you some examples of that. And then there might be areas where neither of those are effective or appropriate. And could we develop that within CCAC, the ability to perform these comprehensive assessments to confirm the patient is indeed high risk, to confirm there has been recent ADL or functional decline, and that they in fact are high risk, that if we aren't doing anything, they may need emerge hospital or long-term care, that there is some restorative potential there, and that there isn't an acute medical cause. And so we did develop a checklist as part of the toolkit of things you would want to make sure are not happening. Basic blood work, as appropriate, minimal laboratory or investigations, or x-rays as needed, which could help rule out an acute medical condition. And then once it's confirmed, they could complete the referral form or the next step in the referral pathway and send that to the most appropriate lead provider, whether that's in step 3, the person receiving the vetted rehabilitative care referral, or in some cases it may be a single agency. I'm thinking, for example, if this was all happening in the emergency department, the person from rehab's come down, done the assessment, and moved them directly into a rehab bed. That could be all done through one process. So we also had timelines associated with this, that from the community we would expect and aim for this process for this very high risk senior with functional decline, that we would want this done from screening to admission within 14 days ideally, and if they're presenting to the emergency department and going within the facility, you'd want that to happen ideally within hours. So that was the process that had been developed through Mandate 1, and then Mandate 2 was looking at, the ministry was funding projects to say, can we, now that we've developed this standardized process, how can we implement it? How can we support this with some key funding, some projects to look to implement this across the province? We they also wanted to pilot components of it to see, were these tools useful? Are we using the right indicators? How can we support this direct access from the community? And then from our perspective at the RCI, we were to continue to support the LINs and the ministry with all Assess Restore related initiatives. So Mandate 2, essentially developing an annual report that's looking at all of these projects to look at the progress of the LIN efforts to implement this Assess Restore guideline, to look specifically at the ongoing evaluation of the direct access priority process, to support knowledge exchange events, training, ANR funded initiatives, and then to summarize and analyze the progress across the system. And that's essentially what we've been working on for Mandate 2. So the Assess Restore monies came out to implement this, and they were divided into what they called cluster categories. So there was a screening tool adoption. So there were projects specifically looking at the AUA and whether that was a helpful tool in this situation. There were more intervention type projects looking at enhancing community service delivery, whether that's in the clinic or whether it's home-based. Looking at enhanced service delivery within rehab or acute care. There were interventions specifically looking at enhancing geriatric training, so looking at these concepts of functional decline, restorative potential, geriatric syndromes, and building that capacity in different settings in order to enable Assess Restore initiatives and projects. And then there were the multi-element projects, so specifically looking at implementing that pathway of screening, assessment, and navigation to bedded rehab, and those were called the DAP priority process initiatives. And then those projects looking at specific funding to aid in the navigation of placement and enhancing formal existing partnerships. So none of this funding. This is all one-time funding that went, I want to say it's about 18 months. I'm looking at my project coordinator.
It was supposed to be 3 years, ended up being about 26 months.
So supposed to be 3 years, ending up being about 26 months in terms of the funding. And we know that this funding is not sustainable. So these projects really aiming to build processes and build capacity so these processes could continue once the money runs out, essentially. So the following slides are, I'm not going to go through them. They're mainly there for your review and to have. These are the different LINs that received funding for this specific project. So you can see 4 LINs noted up there, including the Champlain LIN, where you folks are looking at screening tool adoption, community service delivery. There were a number of projects and a number of LINs funded. There were those for community service delivery in clinic, again, a number of LINs, those who are more home-based models of care, enhanced service delivery, again, a number of LINs. And then here's the interventions group looking specifically at geriatrics training in different LINs and enhancing formal partnerships. So the direct access priority process projects, there were 5 LINs who were looking at implementing that process that we just went through, screening, assessment, navigation, and placement. So I have more details on some of those. Now, some of these I'm not at all familiar with, and some of them I am more familiar with. So again, they're there mainly for your resource, and so you could contact the appropriate people if you were interested. I don't want to talk too much about the ones I don't know about because I would hate to say things that are not true, but certainly there was a DAP process in the Northwest LIN. All of these DAP clusters from these 5 LINs, they would meet fairly regularly. I hate to speak with a bias, but I think this, I'm fairly confident in saying this was a very ambitious and complicated process. As you can imagine, looking at screening in the community, identifying functional decline, moving to comprehensive assessment, then moving to rehab. In many of these places, you're looking at several different organizations getting buy-in on the process, on the concept, on the processes, on the transitions. So fairly complicated. The Northwest LHIN. So in that way, these 5 groups, these 5 projects would meet fairly regularly to discuss barriers, challenges, opportunities, successes along the way, and so they've continued to meet and have come together some recommendations that we will take forward into what's helpful and what was most challenging. So the Northwest LHIN was to introducing streams of care at the St. Joe's Care Group, creating an ease of access to rehab, looking at especially direct access to services, hoping to, again, to avoid acute care. And I don't have numbers on where this project is at. The Toronto Central LHIN, fast access for seniors to community assessed resource services. I think this was called Fast CARS. People are so much more creative than I am. It's much better than DAP. So they developed and implemented a standardized care path, again, to promote rapid admission to assess, restore, inpatient, outpatient, rehab complex, again, for complex, vulnerable patients, frail seniors, again, looking to facilitate these direct admissions from ED, primary care, or community. And they have a frailty intervention clinic that I believe they were referred into and then determined through assessment the most appropriate place for navigation and placement. The Southwest LHIN, and this was a partner which married very closely to us in the Northeast LHIN in terms of the type of project. They were able to lay the foundation essentially for the implementation of the STAT process. They say that they've been able to serve or touch over 3,000 older adults through 7 individual pilot projects across the Southwest LHIN. Some of this educational and as well some to increase clinical capacity. They created a website to support the navigation of community dwelling older adults to the right care. They were implementing proactive risk screening with the AUA, and then again to facilitate improved navigation to the most appropriate community resources. And then they too established and tested pathways and processes for direct admission from the community to vetted rehab. The Central East LHIN, I have to say, is one of my favorite models to talk about. So they looked at facilitated a direct admission to inpatient rehab from the emergency department. This is at Northumberland Hills Hospital, where they had a nurse practitioner-led program. So just from being on the task group and the alliance and listening to the nurse practitioner leading this, she's very well trained with, excellent expertise in geriatric care and awareness of geriatric syndrome. So this individual has led this process. And so when someone comes into the emergency department who's identified, she will come down and do an immediate assessment, including ordering tests, diagnoses, developing a care plan, and that comprehensive geriatric assessment that is done is then creates the care plan for when they transition into the rehab, the rehabilitation floor, and they focus all of their care on the geriatric syndromes that were identified through their process and to provide interventions to mitigate or stabilize these syndromes. To date, they've had, well, the most updated numbers I had was about 320, and that was in June, so I imagine there are more since then. And they're having a high amount of success of discharge back to home. So random sample of 96 patients shows that 91% of direct admissions, so showing up in the emerge with functional decline direct to rehab, and then eventual discharge home. And this is for interest, and they have started to look at, so what were the type of geriatric syndromes that they were presenting or they had at presentation, this is, I suspect, not either or, that many people could have more than one geriatric syndrome. So of the patients enrolled in the 2015-2016 Assess Restore pilot, 88% had between 4 and 10 geriatric syndromes. And 97%, of course, mobility related or falls, 70% pain, 68% mental health. And I don't have a further breakdown on what that means. You don't know, Dana?
Not off the top of my head.
No, yeah, I don't know. And because I saw dementia lower down there, so I don't know, and depression's on there as well, so I'm not sure how that's different. So 57% functional decline, 47% incontinence, 44% depression, and then the list goes on. And so they've denoted success in specifically looking at and targeting the geriatric syndromes, and I think it goes to show how successful a sort of contained model with expertise can be, because as stated, it's as the patient rolls in through the emergency department and is identified, that nurse practitioner who has the expertise in geriatrics does the comprehensive assessment, and it's through identification of those geriatric syndromes and the treatment of, I think that they've been so successful in enabling to get people home. So this project, and I have with me Dana Corsi, who is the project coordinator for the Northeast LHIN Assess Restore Collaborative, so that I can pick her brain as we move forward, because I won't have quite the detail that she has. But we did in the Northeast LHIN. So the Northeast LHIN is, just for those of you who aren't as familiar, we have quite a vast geography. So the Northeast Specialized Geriatric Center, which I lead, is we have a mandate to cover the entire Northeast LHIN. So from Parry Sound up to the James Bay coast. We like to say square footage wise the area of Germany, but of course sparsely populated in regions, and so obviously a one model fits all approach doesn't work for us, and we have 2 geriatricians in this LHIN, one of whom is hospital and research based, and then myself community based, and so we work collaboratively with our care of the elderly physicians, and then with our primary care partners in terms of trying to implement geriatric care. So we thought there were a couple of opportunities because we had NESGC physically located in Sudbury, and we had recently developed and funded the Algoma Geriatric Medical Clinic out of Sault Ste. Marie, which is led by Frank Ayani and a couple of other physicians who have received certifications, care of the elderly, and a multidisciplinary team. That there would be, and in both areas we also had Okay, good, perfect. All right. So I don't know where I left off. I was talking for a while before before I figured out that. So I was in my brain. I was at the piloting in the Sudbury site for the direct access priority process. We chose several sites. One, City of Lakes Family Health Team, where we were taking the process at its word, where we were seeing if we could create the screening assessment within primary care model and get direct admission to rehab through primary care. So we do have a partner with the City of Lakes Family Health Team who have created expertise within their nurse practitioners who are excellent geriatric assessors. And so worked with them on using the AUA, which they use to screen. They use their clinical impression, and then we worked to develop a process where they would be admitted directly to rehab. We did that through our own referrals to any specialized geriatric services, and then tried to develop as well this model through NEOMO, which was a family health organization, again looking at AUA, and we provided a geriatric assessor to NEOMO, who, if they identified one of our geriatric assessors, would react within a timely manner to provide that direct comprehensive geriatric assessment, collaboration with the geriatrician, and then direct to rehab. So STAT is sort of, I guess, along the lines of more of an outpatient day hospital type model, although I wouldn't say it's quite to that level, but to see if we could create that process. So in total, with 37 patients referred through ARC, 30 admitted to bedded rehab. The folks who didn't make it to rehab, a couple had actually more medically acute, and so had to go to hospital or were too acute for rehab. A couple chose not to go, and a couple not appropriate. Yeah. Once we referred for bedded rehab, it wasn't the best place for them. So in Sault Ste. Marie, this was a very different state of readiness. A lot of transitioning happening at the Sault Ste. Marie site, internal restructuring, a lot of education, onboarding needing to be done. The screening and assessment actually through Red Cross Assisted Living, the assessments and identification all through the Algoma Geriatric Medical Clinic, and I don't know what other is. Does that emerge?
No, it was primary care.
Oh, primary care. A couple identified through primary care, and again, 7 referred, 4 bedded rehab recommended, and 3. And so we've recently been successful at acquiring funding for a geriatric medical clinic to be in Timmins, led by 2 care of the elderly physicians there. And so we will be moving to pilot that project in Timmins. So as part of the process, geriatric knowledge was identified early as essential in terms of, I just can't say enough about how much education had to be done with these groups, with all of us, in terms of figuring out everyone's processes, but also just looking at the concept of geriatric functional decline, geriatric syndromes, how to identify restorative potential. And we actually, as part of the project, hired a full-time geriatric knowledge educator who helped. We had educational events focused at screening, focused at assessment, coming together to create pathways for navigation and placement, education focused. So in the second mandate, more on the geriatric rehabilitative care arm, and then additional education in geriatrics. And I'll try to skip through here now, looking at times. We also understood the importance of creating clinical champions. So 20 clinical champions were identified, where they were, so 10 in the Sioux and 10 in Sudbury, where many went to Ottawa, in fact, to complete the geriatric education series. We did education provided by myself. We did, and then many went to London, in fact, to visit the geriatric rehabilitation unit at Parkwood. There was interprofessional education provided, and then a Southwood site visit. So all of these targeted efforts to facilitate the uptake of geriatric best practices, because as we are moving these patients through, we had to ensure that not only do we know what we're looking for, but once people arrived in rehab, people knew what to do with them. And this is an ongoing. Many of these processes are ongoing still. So I'm going to skip. These are really great slides, but in the interest of time, I'm going to skip through. Dana, I apologize. So, I mean, for step 1, there's 6 community pilot sites across the Northeast. We were requiring essentially an adoption of a new language, of new tools, of new processes. The concept of functional decline, of restorative potential, of identifying reversibility and moving them into rehab, and develop the standard approach. It was a lot of building of trust as well. We learned about the importance of a warm handoff, so that conversation. So as much as we wanted tools and processes, so much came from actually picking up the phone and having the conversation that really facilitated, at least in the early days. I think getting to trusting a form or trusting a tool might come later on, but for now it was really important to have those warm handoffs because to a lot of the times the paper would go in and rehab would say, well, this, I don't know if this is appropriate, and then they want to go back and do another assessment, and we were saying, no, we don't want to keep assessing. We have to build trust in this process. And so, with time, I think a lot of success for that. So those who were doing the comprehensive assessment, so in Sudbury, we had ourselves, we had the family health teams doing comprehensive assessment, and in the Sioux, it was the Algoma Geriatric Medical Clinic primarily. We are looking to expand into the ED moving forward, and then in Timmins, we're still working on that. Referral navigation and placement. So we continually modifying this process. I think this is more what I just talked about, is how do we enable direct access to bedded level of rehab from the community, the importance of that warm handoff, and what is this slide telling you? You help me with this one.
That our patients had to access primarily bedded level of care to meet their needs.
Oh, right. So this is right. So this is what Dana tells me is that, so I'm not sure about this comparison. So we, essentially this is Northeast Assess Restore Collaborative, where essentially every person we screened, we sent them to rehab. And then of course, if you look at Southwest, everyone who screened and was assessed, you had some people being referred to geriatrician clinics, some day hospitals, some to CCAC, some inpatient rehab. And the thought is that because they have more resources than us and more opportunities for navigation than we do? I'm not so sure about that. I think there is a component of that. I mean, we certainly don't have a functioning day hospital. We certainly don't have a GAU, like a geriatric assessment unit. Where our community support services are there, but they're not well coordinated, I would say, for the frail older adults. But I mean, we still have our clinics, we still have our program, we still have primary care, we still have some episodic care, and the STAT program does provide outpatient rehab and outpatient multi-D. So I think what I think probably happened when you're comparing these two is, I think we did a lot more directed case finding versus screening. And so I think that we probably already took off the top where people should go. And then if we felt they were ARC bedded rehab, fit them into this 98%. So I think it's a much less heterogeneous population that went through our process than the Southwestland. But that is my interpretation of this. So that's just an interesting comparison, is that we both did two very different, very similar projects, and they seemed to pull out a much more heterogeneous population, where only 8% went to bedded rehab, where just about all of ours did. So again, outcome opportunities. We thought a lot about this concept of not a typical rehab patient, of when we get folks into rehab, not looking specifically only at mobility, but having to focus on the geriatric syndromes. It provided a shift in thinking, so that balance between prioritizing patients coming from the hospital versus the community. This concept of geriatric rehabilitation bedded for functional dining in the community was new, both in the Sioux as well as in Sudbury, and there really isn't a geriatric rehab currently available in the Northeast. So we have slow-paced rehab beds and assess restore beds, but they are not linked to a geriatrician. They're not linked to care of the elderly-based physicians. The physician model is currently in flux, and so it is working with different resources. And then again, this concept of, we don't have a ton of community-based specialized rehabilitative care services, and so does this warrant us utilizing those beds a little bit more heavily? And I think we won't know that until the future. So recommendations for sustainability. So we think, as the money's running out and we're looking at this process, we need to be looking at geriatric knowledge. We need a dedicated system resource, we think, to be continually coordinating geriatric education. How do we continue to support this early identification processes? Can we get a standard approach to spreading this regionally? How do we develop this capacity and availability for comprehensive geriatric assessment? And there is work at the RGP level on looking at core competencies and comprehensive geriatric assessment, and how we can bring this into the community and leverage that possibly to getting folks to the most appropriate level of rehabilitative care. And then what are the resource gaps in vetted and community-based specialized geriatric rehabilitative care in both destinations and providers? We didn't talk about transition, so that's not something we were piloting in 1 and 2, but of course you can't really do it without transitions, and that work is ongoing in Mandate 2, and I think we'll look more at that in Mandate 3, and what is this handoffs at each transition point. If we do all this work and then discharge without appropriate support, without appropriate support of the geriatric syndromes moving forward, of appreciation that functional mobility can be lost quite quickly again, and how to build that into transitions, and then regional leadership. So this ongoing evaluation for capacity and human resource needs will be an ongoing issue both for us and then moving forward provincially. So in summary for our project accomplishments to date, there are 5 DAP projects in process. 100% of the projects were using the AUA. Some found it useful, some not, and so we can talk about that if you like. 4,000 frail seniors have been used through the DAP process, an average of 97% discharged back to the community. Reduced wait time for admission to rehab care beds from the community and emergency rooms have been noted. And certainly we think there's been a greater understanding of restorative potential of geriatric tools and syndromes due to increased education, at least in our area. So the ministry invested $8 million in 2013-14, 10.7 in each of the following years, one-time funding to all 14 LHIN for these projects. A key consideration will be how are we going to move forward, as there's no word on new money or new funding. The RCA is continuing to support these initiatives and is certainly in the process of developing the work for Mandate 3, and there is a collaboration there with the Regional Geriatric Programs of Ontario. The RCA will summarize the key components and learnings across these initiatives, and there will be another report. And this continues to be done in collaboration with the provincial stakeholders. So that's where I'm at. I know that sorry doesn't leave us a lot of time for questions. There was apologize for the technical difficulties in there.